it as short and sweet, but useful as possible. Okay. And just interrupt me if you have any question. I don't see you. So I'll just be basically just shout if you have anything. Did you see my presentation okay?
Yep.
Yes, we
Okay.
do.
Sounds good, perfect. So basically we're going to talk about hypertrophic cardiomyopathy in neonates. And really it's really a hemodynamics focus. So I saw as well there's people that are not turning in hemodynamics. So if ever you have any question, I'm using terms that are maybe a bit too technical, just let me know and I'll explain myself, okay? So so basically so honestly, it is a very interesting topic. Is it something that we see often as children? And there is actually not a lot of literature in neonates around it. There's some case reports, but there's not a lot of like guideline to really dictate the management and the approach to hypertrophic cardiomyopathy in neonates. There's definitely more in pediatrics, in adults, but not as much as in neonates. So really, in adults, HCM is characterized by LV hypertrophy in the absence of another cardiac or systemic etiology. And they usually basically use in adults, again, an unexplained maximal wall thickness of more or equal to 15 millimeter in one or more myocardial segment, or more or equal to 13 millimeter in the presence of a positive family history. That's really for HOCM, okay? But then in our neonates, what do we see? So first of all, when do we actually see hypertrophic cardiomyopathy in babies? So I would say, as you all know, it's usually it's usually seen basically and suspected in our babies that have that are infant of diabetic mothers, but also it can be seen in many other presentation and secondary to many other etiologies, which are important to keep in mind because there are early managements for those genetic and also metabolic condition. So when we talk about other cause basically of hypertrophic cardiomyopathy, we think about some malformation syndromes such as rhizopathy, so including Noonan's, including Costello syndrome. We can think about some metabolic conditions secondary, such as like Pompe disease, and also some mucopolysaccharidosis. And in our neonates also, I have to say, we are called as in the TNE also, and also in part of research project to assess the hypertrophic cardiomyopathy secondary to corticosteroid use. And that's, I would say, another big etiology that we assess basically in our unit. So basically, again, I'm not going to talk about IDM because that's not really the purpose of this talk, but I'm going to talk to you a little bit more about just in general, like what do we see in our IDM from a cardiac standpoint. So in those babies, they tend to have cardiac comorbidities such as obviously congenital heart disease, cardiac muscle hypertrophy, and they can have also cardiorespiratory maladaptation syndrome. So in 30% of IDM will have a septal hypertrophy. And it's usually when obviously the diabetes is not well controlled in the pregnancy, but it can also be seen in mom that have a good glycemic control in their pregnancy. So we can detect it as early as 18 weeks of gestational age on antenatal ultrasound. And in the babies with IDM, it's really the septum, so the intraventricular septum, that will be hypertrophied because there's actually more insulin receptors at the septum site. And so basically, this is actually quite a typical feature of this. But if ever it gets quite severe, then obviously it can extend to the other parts of the myocardium. And contrary to like syndromes such as like Noonan or other more like genetic etiology, the in IDM, basically, their HCM tend to have hyperplastic cardiomyocytes that are actually in a normal configuration. So they're not all like in a disorganized and everything. And that's probably why basically the hypertrophic cardiomyopathy is reversible and prone basically to less prone basically to arrhythmia. And so I mean, the point of saying that is that, you know, I don't think it's necessarily to do an echo in every single baby with that which mom had gestational diabetes, but I think it is definitely important to keep in mind that if there are infant of diabetic mother that have clinical signs of low cardiac output or pulmonary hypertension, then they should definitely get either a TNE or an echo for sure during their stay. So this is just to show you that, again, and we're going to talk about it in one of our cases, but we really need to make sure, you know, we don't fall in our usual, you know, pattern and just obviously, and things are common things are more common. So obviously, we are more going to see hypertrophic cardiomyopathy secondary to steroids or diabetes in the pregnancy. But also, it's important to know that if ever your patient hypertrophy is you know quite significant, you don't find a cause basically to explain it, or you think it's mom had diabetes, but then it actually gets the hypertrophic instead of getting worse is instead of getting better is actually getting worse, then I think it's important to really have a broad approach and really consider those metabolic and genetic condition and do basically associated screening tests readily in order to diagnose and also treat those conditions quickly. So in short, if you in adults basically, the hypertrophic cardiomyopathy has I would say 4 different present I would say arrangements. So so the first anatomic variant would be the neutral one, where you basically have a straight septum and it's not like it's just big, but it's not going more bulging on one side over the other. And then you have the sigmoid, which has like a bulge at the base, basically, of the heart. You have the reverse curvature, which really forms some sort of a croissant, basically, and that has basically a septum convexity in the LV cavity. And then lastly, you have like the apical hypertrophy, which is really basically present at the apex of the heart. Okay, so in short, hypertrophic cardiomyopathy is super interesting from a hemodynamic standpoint because it impacts so many things and it's all interconnected. So I'm going to make it as clear and easy as possible. So again, this is a very good picture that I took from the AAC Comprehensive Echocardiography book. And again, it's based on adult. So I would say it's most important to understand that in our hypertrophic cardiomyopathy, we're going to watch closely for diastolic dysfunction and LVOT obstruction. And also, we're obviously going to make sure our baby doesn't develop at the end myocardial ischemia. The atomic dysfunction, I would say, is something that we concentrate less basically in our babies. So in short, so we'll talk about diastolic dysfunction first. So during in babies basically that have hypertrophic cardiomyopathy, they'll have increased muscle mass and they'll have also decreased ventricular volume. So there's less space actually for the LV cavity to fill. And also there'll be impaired ventricular relaxation too because of all of that. Another thing that will be worsening basically that diastolic dysfunction is that HCM babies have impaired handling of their intracellular calcium, and so it delays the activation, delays the inactivation basically, and worsens the diastolic dysfunction. We'll talk a little bit later about how to assess diastolic dysfunction in babies, but this is just an overview of like the different pathophysiologic pathway or mechanisms that are seen in those babies. So because you have that diastolic dysfunction, So you can have actually more blood basically that doesn't get that kind of that doesn't is passed inappropriately basically in your LV, and then goes basically in your LA. And then basically it can actually rebound into your pulmonary circulation. And we are concerned at that point that you can develop post-capillary acute pulmonary hypertension. So there's something also to keep in mind in our babies with HCM. Because the diastolic dysfunction is important not only for filling, but also for perfusion. So as you know, coronary perfusion, so the heart perfusion happens in diastole. So basically, the HCM babies can have myocardial ischemia because obviously they have that diastolic dysfunction, but they also have increased wall thickness, increased LV filling pressures, and they have also their coronaries that get thickened, and all of that can impair basically their function. Lastly, there is also a dynamic LV obstruction basically that you can see that we'll talk more about, that we call the SAM, basically the systolic anterior motion of the mitral valve, and of the leaflet, I would say. And so basically, this will also be associated also with mitral regurgitation. And because you have basically an inefficient heart, you'll have increased LV systolic pressure that will prolong the ventricular relaxation, elevate your LV diastolic pressure, and decrease at the end your LVO. So I think it's a lot of processes, and I think it's just important to remember like the big lines of all of that, but we'll go through it a little bit more practically. So first of all, what happens with SAM? So this is so SAM basically is the movement that you see right here basically of your of your mitral leaflet. So basically you'll have your septal hypertrophy, you'll have the narrowing of your outflow tract here, and then you have abnormality of your mitral leaflets and also a malposition of your papillary muscle that are caused by your hypertrophy. And all of that will basically move the anterior and superior, your anterior mitral leaflet into your LVO, your left ventricular outflow tract, and obstrude it basically. So this is kind of an echo picture which shows here without the SAM that there is a good outflow tract here that is open, but you see here that your mitral leaflet, your anterior mitral leaflet is actually obstructing that pathway, and then basically there's less heart that can be basically brought into your systemic circulation right here with the SAM. So I mean, again, a picture is worth 1,000 words. I'm just going to see if I can make that happen. So I have a little video that can be a bit more useful. It's the blood flow. So I'm just going to see if I can share it. So here, do you see?
Yes, we see
Yes.
your YouTube. Yeah.
Of the left ventricular outflow tract.
Do you hear?
Yes, we hear.
But you see here basically that you have your anterior leaflet that will basically during systole will really obstruct basically the outflow tract and prevent basically from your blood to go into your systemic circulation. So that is, I would say, a little bit of a easier and more clearer way basically to explain it. Okay. Then I'm just going to zoom out here and then reshare. Here, perfect. All right. So all right. So So again, a little bit more hemodynamics, but basically this is a very old that's like an article from 1995. But I mean, you get the gist by looking at the images. So you can actually assess the SAM with a 2D image, basically that you can see either on your long axis, but you can and also you can see it too on your apical 5 chamber. But you can also actually use your M mode here and see basically the and basically drop your cursor right here, and you're able to actually appreciate in another way basically your SAM, so that is seen basically in systole. So just going to move that. Okay, so basically here you have your ventricular. This is basically your LV chamber that you see here, and so this is in diastole, this is in systole, and so you see here this is the beginning of a SAM basically that is slowly going to touch basically the septum. And then this is like a full SAM. Oh, sorry. This is a full SAM basically where you in systole basically where you see that you have definitely like that contact that happens that blocks basically the outflow. So this is something that is quite important to understand and recognize basically in echoes. The other thing to talk about is the mitral regurg. Again, full disclosure, thanks Gab for a Neocardial lab. This is an image from your website. So basically, this another thing also to really recognize is that you can have SAM-related mitral regurgitation. So in HTM, so your anterior and posterior mitral leaflet actually fail to fuse, like to co-op in mid-late systole. And basically, this is due to the movement of the anterior leaflet to the septum. And so it is not like a primary mitral valve issue. It's secondary basically to your hypertrophy. And so the mitral regurgitation is directly will happen basically posteriorly in the SAM. So if it doesn't happen posteriorly, then we should consider more of like a primary valve issue here. So here, just for people on the Zoom, so you can see this is the left heart right here, and this is the ventricle. This is this is the atrium right here, and so you see here that you have the blue jet basically is the mitral regurg that you appreciate here. That shouldn't be, this should be red. Another thing basically that can be useful when you assess a baby with your echo is that you want to also see basically your dynamic outflow tract obstruction. And so your CW will be helpful because you'll see actually an asymmetric leftward concave contour and late systolic peak of the maximal flow velocity. So it has a pretty good correlation basically with the LVOT gradient in adult, but it's important when you measure not to make sure basically it is not influenced by the mitral regurgitation, and also not to confuse it basically with a fixed obstruction. So this is basically an image is worth 1,000 words again. So this is what I mean by that, is that basically if you put a CW in your LVOT in your left ventricular outflow tract in a 5-chamber view in your apical in an apical view basically, then you'll see basically at first your like the leftward concave contour here, and then so basically the heart is really trying like to push. It's hard, takes more time, and then finally it happens, but it is basically a little bit later on than if you wouldn't have that an obstruction. And then basically if you would have a fixed obstruction, that's important. You wouldn't have like that asymmetric shape, but rather like a symmetric shape of your Doppler. So this is something, again, that is a little bit part of the objective of this presentation. It's also a bit technical, but I think it's quite important basically in this condition and also just in general in the neonatal hemodynamic ward. So I'm going to briefly talk about that though, because we could spend an entire presentation talking about that. So as I said, in babies with HTM, we definitely can see and often see diastolic dysfunction. And in general, basically, diastolic dysfunction in our babies is quite important because it's often seen as a precursor for systolic dysfunction. So it's important to kind of look for it in any of your echoes, to look for to make sure basically it can be like an anti like a sign before basically the systolic dysfunction happens. So basically LV diastolic function, it depends basically on the balance between relaxation and compliance of the LV, and it also depends on the LA function. So important to know, so newborn hearts basically are less contractile, they're less compliant, and they also have less filling time because they have a higher heart rate. So all babies, whether they're term or preterm, they're born with a mild diastolic dysfunction. And so basically, you can, one way basically to assess a diastolic function in our babies is to look at the EA ratio. So this is seen as you can see on the image A right here. If you place basically a pulse Doppler at the level of your mitral valve, and you'll actually obtain basically this figure that you see in image C. So the E wave represents basically the peak pressure gradient between the LA and LV at the onset of diastole, and it's affected by the rate of the LV relaxation. Then you have basically the period between the two, basically like the mitral E-deceleration time, that is the period basically of time to equalize the LA and LV pressure. And then you have the A wave, which reflects basically the pressure, obviously, gradient between LA and LV in the late diastole. And it basically represents like the atrial contraction. So in short, your E wave is like your passive feeling that happens. And then your A wave is like, bam, you're just like emptying it completely with your atrial contraction, or at least you're trying to make it complete. And so, this is like the two big, basically, period during diastole. So neonatal diastole is more dependent on the atrial contraction. So most of the feeling basically of the LV will happen during the atrial contraction, due basically to that mild diastolic dysfunction. So in babies, you will have, it is normal basically to have a wave that is bigger than your E wave, and this basically will normalize within the first week of life until like a month of life or so in babies that are born prematurely. It can take a little bit longer, but as long as it's improved, that's okay. So as I said, so it's normal in babies basically just after birth to have a mild diastolic dysfunction. Well, you'll see basically that your E ratio is less than 1. But when it gets worrisome is basically where you start having a restrictive ventricular feeling that decreases your ventricular compliance of the LV. So then basically your E wave becomes dominant, and then your A wave decreases, and then basically you'll have a shortened E descending time and also an IVRT as the LA pressure increase. So basically, when you start seeing that the E is much bigger than the A, then you get to a quite worrisome diastolic dysfunction. And so if you place basically your, so I would say there's multiple numbers in the literature, honestly, but what I found basically in two very good sources that you see on the bottom of the screen is that, you know, you can expect severe diastolic dysfunction if your mitral EA ratio is more than 2, and 2.1 in the tricuspid ENA. So again, as I said, there's no single echo parameter that will define diastolic dysfunction in babies. But there have been a few studies basically that have looked at like normative values. There haven't been defined yet. There are some trials that are done, basically including the diffuse trial that is being done to find normative data. The diffuse trial is actually done with Dr. Dempsey that we just saw last week. So again, that will be quite interesting to follow because it's still ongoing. But basically, normative value that you can use would be a LA volume more than 1.5 mils per kilo, a EA ratio of more than 0.9, sorry, a TDI septal E velocity of less than 2.7, EE prime ratio more than 10, and a TR velocity of more than 3.2. There is obviously a limitation in using your EA ratio. So your EA is preload sensitive, and it can be fused also if the baby has quite a high heart rate. So this has also its limits basically, and sometimes we may need to use other markers basically to evaluate that. So in short, I just made a little summary table basically to kind of go through what I just said. I hope it was clear, and you can stop me again if you have any question. But basically, so whenever like we're called to assess basically hypertrophy, or that we find the hypertrophy on our TME incidentally, I think it's important to look for obviously at the EA mitral ratio, to do a TDI to look at your septal E prime, then to look at all the things I just talked about. Your ASD PFO shunt direction will be useful, and your pressure gradient too, to see also how much your RA is incrementing your LA, that is basically not able to offload on a very like tight LV. And also you want to make sure basically that your LA is not overloading too much your RA from basically that atrial connection. The TR velocity will be useful from a sense that if ever it backtracks basically into your right ventricle, basically, then you'll see basically that you'll have like a TR velocity that will be bigger. And then we obviously, another thing that we look for is to look at dynamic LVOT obstruction. So you'll look for your SAM using your TGM mode. You'll you'll look at your LVOT CW shape, your mitral regurg, your LVO, so your LV output, to see basically if it's decreased. And then you'll look at other markers of hypertrophy that I'll talk after, which are basically if you want, you can obviously just see that the heart is hypertrophied from a qualitative way, but you can also measure your intraventricular septum. And you can also see that there's hypertrophy. There's like basically like a narrow LV cavity. If you have flow acceleration in your LV cavity. I'll show both of those after. Importantly, obviously, you want to assess your biventricular systolic function, and you want to look for post-capillary acute pulmonary hypertension in those babies too, as I described earlier. So basically, again, I was trying to see if there was like I don't think there is like a gold standard on how to measure your ventricular septum basically, and what would be the best like Z-score rule basically to use. But I think this is a pretty good one. It's actually Canadian. It was published just this summer, I think. And Dr. Cavalli was actually one of the authors on this one. But basically, this is basically like a big my God like a research basically that look at thousands of echoes to basically be able to calculate different Z-score for different cardiac measurements, and they actually included 1,573 neonates in that, so that's pretty good. And so you can find this in parameter Z whenever you and that's obviously accessible through Neocardial lab. So basically, you can go on parameter Z, click echo, then choose Canadian Congenital Pediatric Cardiology, etc. And then you can actually find on top of the list intraventricular septum. And then it tells you basically what you need to measure. So in this research, basically they recommend basically to measure the intraventricular septum using the parasternal long axis. Exactly. And also there are others basically where you can use your parasternal short axis, but it's kind of the same principle. Oh, Laurence? Did you have a question? Are you muted?
Laurence, your hand is up. So do you have a question?
Sorry, yes, I had a question, but I'm sorry, the Wi-Fi is not the best in block. So my question is, a few slides back, you were talking about the parameters to look at when we have, yes,
This one?
le tableau, like the,
Oh, wait.
no, the one,
Okay.
wait, the Wi-Fi is really bad, but okay, this one, yes, this one, okay, yeah.
Okay.
And I was wondering why, like, you would use TDI septal E prime, because the hypertrophy is mostly on the interventricular septum. Like, if you have like concentric hypertrophy, could you use also the left wall E prime? Do you know what I mean?
Yeah,
Like,
yeah.
why only
It's
the
just that
septal E prime?
very simple. It's just because in this study from the wall that was published in
Yeah.
Pediatric Cardiology, they use septal E prime. But I think
Oh,
you can
okay.
use it was that it's purely that, honestly. But basically, like if you want to measure your yeah, exactly. So I think here they want a the septal E prime, but because this is the normative value that is available. But I'm
Okay,
sure,
good.
like, I think, like, with more studies that are currently on the way, basically to get more reference value, I think we'll probably, hopefully, have more for, like, the lateral or extra.
Like the free wall of the LV. Yeah, I was just wondering.
Yeah, exactly.
Yeah, thanks.
No problem. So in short, I think what is important to know basically from this slide is that and I mean those slides will be available if you want them. I'm happy to share them. Obviously, there's no problem. So basically what is important from this slide is that usually if you have a left ventricular wall thickness or LV posterior wall that is more than the second standard deviation above the predicted mean corrected body surface area, so basically if you score more than 2, then it is concerning for HCM. Another thing, as I said, to look for, so hypertrophy, right, is the thickness, but also to look for a flow acceleration in the LV. Again, this image I took from Neocardial lab. Thank you so much, Gab. So basically, you'll have like less space for that heart to for that blood basically to fill the cavity. It is hyperdynamic. It goes basically quickly in, quickly out. And so you'll see it's kind of it's kind of seeing basically like a glitter, basically a quick like flash basically of blue on your red. Basically it's just like very you see like kind of some sort of a anyway, this is the way I kind of think about it when I look at it, but basically like it is a lot of turbulence essentially in your cavity. And also in this image you can see mitral insufficiency that you see right here too. So obviously if you're dealing with hypertrophy, if you want to do an ECG, although I don't think we do it often, but you're going to look for LV enlargement, biventricular hypertrophy, possibly pre-excitation, and then sometime in Pompe you can have more specific findings such as a short PR and a biventricular hypertrophy. Okay, so I think this section is quite important. But again, like I'm open for your comments and experience on that, because honestly, their clinical management of neonatal hypertrophic cardiomyopathy is quite variable. There's no consensus. There's not a lot of literature. So again, I'm kind of telling you basically what I've seen, what in my time in clinic, and also obviously what I found basically from literature review. So in short, when you have your hypertrophic cardiomyopathy, super important, you want to improve that LV filling. That is so in that ventricle that is so small, right? So you want to optimize preload, which can also help and basically to increase your preload will also help to decrease basically your LVOT obstruction because your ventricle will be more open. You want to avoid tachycardia because that tachycardia decreases your filling time. So you want to avoid catecholamines such as dobutamine, dopamine, and epinephrine. You want to make sure the patient is normothermic and is under good sedation if needed. You want to avoid hypotension. You want to make sure that those patients basically have a very good afterload, which will keep better filling and also will help with the preload too. And then basically sometime if needed, it's not a sine qua non, but only if you're stuck and there's and it makes sense too, you can actually consider an intubation because this will also increase your transmural pressure gradient and basically like it can push on your LV and support basically your LV function too. In those patients, as I said, it's important to watch closely at your calcium to make sure it's not decreasing. And and basically in those patients, if they are hypotensive, you will talk about that, but essentially this is a specific situation where you want to use fluid and then consider vasopressin. And then, as I said earlier, if you have acute pulmonary hypertension, either like an arterial one or a postcapillary one, you want to make sure you're using vasopressors if they're used, basically that will not increase your pulmonary vascular resistance or your heart rate. And those patients, it's important to remember they will need outpatient follow-up, so that's important to arrange that. So in short, beta blockers are quite useful in managing hypertrophic cardiomyopathy. It's mentioned in all basically the adult and pediatric children literature. So basically, the beta blocker that we use mostly in the NICU are propanol when you use it PO or esmolol IV. So the beta blockers are used basically for heart rate control, and they will and especially basically if you see basically that your patient is quite symptomatic, so has decreased diastolic filling or has LV outflow tract obstruction. You should not use beta blockers if your baby is hypotensive and if they have acute pulmonary hypertension too. And plus minus if you have systolic dysfunction because it can actually worsen your dysfunction too. So what your beta blockers do is that they decrease your myocardial contractibility, and that will consequently reduce your SUM and reduce your LV outflow tract gradient. And so your beta blocker, and they do that because they have a negative inotropic effect. They also can attenuate basically the adrenergic induced tachycardia, and they prolong the filling time. So I would say the doses that I've seen basically recommended are usually a dose of esmolol up from 50 to 100. You can titrate it around that, of course, and then you pass it to an oral dose of propanol, which is like 3 to 4 milligrams per kilo per day. And it's usually easier to start esmolol in hospitalized patient because it's ultra short acting. So if ever something goes wrong, you can stop it quickly and manage it, and then basically the effect goes away quickly. Whenever you use basically beta blocker, you need to make sure basically you don't precipitate or worsen a heart failure, especially if you had myocardial dysfunction. You want to watch for bradyarrhythmias, hypotension, and also hypoglycemia, as you know. On the other hand, propranolol basically is obviously a little bit more long-acting, definitely more long-acting, I would say, and also is not like a quick titration like esmolol, obviously. Propranolol needs basically to be weaned slowly before cessation to avoid withdrawal. So something that is also so interesting basically is so I would say if you have basically a patient that is the way I see it is that if you have a patient basically that is having hypertrophy and that is basically having some tachycardia, that is having some that you see on your echo that the hypertrophy is significant. There's not a good feeling. There's LVOTO, but the patient is not unstable without like hypotension or anything. Then I think it's fair basically to use your beta blocker whenever you have symptoms basically, but that are not bad enough basically to create like hypotension. I would say this is the way I see it at first. Then whenever you have a very sick patient, I would be reluctant at first to use a beta blocker because again you can then compensate your function, and so induce hypotension, right? So in those patients, I would actually use this algorithm and it's actually a great article that was published in 2020 in Journal of Perinatology from Iowa and Sick Kids. Basically, they said that if ever you have hypotension, obviously you want to really like give preload, so provide volume expansion, and treat obviously your fluid losses. You want to make sure you manage acute pulmonary hypertension if present. And then if you've like optimized the more you can your fluid and you're still hypotensive, then you actually consider vasopressin. And so basically, I found it was quite they had a practical approach. They did give basically those ranges, increase, decreases, so that I just put them there if ever you find it useful. And then basically down the road, if ever like you're still having LVO2 obstruction, but you're having a normal BP, then you can consider basically an APH, basically, then you can consider basically your PG, basically to give another way to give systemic blood flow. And you consider basically esmolol here because basically you have a normal BP and you're not in a residual hypoxia, basically, or in an acute pH. So they had a good, they showed basically that vasopressin was quite useful basically to improve the gradient. And as you can see, the pre-vasopressin and post-vasopressin gradient were quite different, were quite, improved. So what does the vasopressin do is that basically, as you know, that's kind of a review, but always good to go through again. So basically, as you know, your vasopressin will basically have a lot of different mechanism. It activates basically your V1 vascular receptor and inhibits your NO-induced vasodilators. It can, in animal, you can see that it does a coronary vasodilation. It can also increase your preload through your increased renal free water reabsorption, reduces your heart rate via the V3 receptor stimulation, and it can also improve your RV performance through pulmonary vasodilation. Yeah, and obviously watch for hyponatremia in those babies. So I would say we're going to discuss that briefly. I'm looking at the time now. Like the management of things basically that you should not do in hypertrophic cardiomyopathy, because recently I think we had cases that we didn't really follow that. But I would say, like, I think as a general rule, to keep in the back of your mind, you want in hypertrophic cardiomyopathy, you really want to avoid increasing your cardiac your heart rate basically. So you want to avoid basically catecholamine, because they can also basically worsen basically your LVOT obstruction. And your milrinone is also something that is not typically recommended because you can actually decrease your afterload because it can cause some vasodilation. Obviously, there's other therapies that can use that we won't go through it, but just to keep in mind, like the babies basically that don't have a IDM or that have a secondary hypertrophic cardiomyopathy, the ones that have like restopathy or extra can have a heart transplantation, and they also have a specific management based on the cause. So let's say in restopathy, they'll definitely need beta blocker. They may need a surgical myomectomy down the road, and the pump adhesive have actually enzyme replacement therapy that can be used too. So that's the end of the presentation. Before we go through the cases, again quickly because I saw I see the time now. Do you have any question on what I said? All good? Okay. Okay, perfect. Gabriel, do you want to go on single?
Yeah, you know what I'm gonna do, Sarah? I uploaded the just to not name any identifiers. I've uploaded anonymized version of the echo of this week. So I'll share my screen for that case.
Okay,
And then
perfect.
for the second case, we'll stop the recording and then I'll let you go through the single. Should we do that?
Yeah, that's fantastic. Yeah.
Okay, let me just share my screen. So let's see. Just a second. Let me see if I can. Just give me a second. Okay. And copy link. New window. Okay, it should work.
Okay.
Are you seeing the screen?
Yeah.
Okay, perfect. So I'll cut my microphone and I'll let you guide me to advance the screen or not.
Oh, okay, I see. Yeah. So this is the one from yesterday, right? Just making sure.
Exactly.
Okay, perfect. So I'm just going to describe this case without obviously any identification information. So in short, this is a baby that was born at 34 and 6 weeks. That was 11 days old when this echo was done. And so it is a IUGR female that had at birth a finding of a large liver hemangioma, most likely that was seen in her liver, and she ended up being seen basically by the hemodynamics/cardiology team because this baby had severe pulmonary hypertension at birth and also cardiac dysfunction. And so this baby was managed basically for her pulmonary hypertension with milrinone. She also required INO, and then to help basically with her cardiac function, she obviously was started on milrinone, but also had required epinephrine. So on her first, and basically all of that was probably secondary of anemia that was secondary basically to that hemangioma, and also because there was a high output cardiac failure that was even seen basically antenatally, secondary basically to that liver and hemangioma or other liver lesion. They're still trying to understand the nature of it. So, in short, what is important to know here in this case, in this context, is that this baby had initial biventricular hypertension at birth, which was mild, and this was thought to be secondary to just high output failure, most probably. But this baby basically was started on steroid in the context of her liver hemangioma, and and on quite high dose steroids. And when we could see basically on her following echoes is that her cardiac hypertrophy was getting worse and worse and worse. And so this was an echo this is my echo from yesterday, or this is yours for Friday, Gabrielle?
It's yours.
Okay, perfect. So this is an echo that we did yesterday. So as you can see, and do they move or not? Okay, super. So so basically, as you can see here, this is a parasternal long axis. And so you can see here, it's quite a severe hypertrophy, honestly. So this is basically your. Do you see? I'm not sure if you see my mouse, but in short, basically, you see that you have a severe hypertrophy. Um, of your septum, your posterior wall also looks hypertrophy to here, although I didn't measure it. And you have here too, like a sum that you clearly see, and you have and you see basically that you have really not a lot of blood flow that goes through your cavity here. And you see kind of some flow acceleration, but also at the same time here it's difficult to see because there is not much flow that you can see. And you see too, yeah, and mitral regurgitation too that you see that you can see right here in blue. And as we talked about, you can actually see a SAM here. So on the M mode, basically, that was done on this echo. And so you see basically that the leaflet touched basically your septum here. So that's interesting. What else? I would say I think it's also just to talk about this too. So you see again, this is your parasternal short axis where you see that you have quite a severe hypertrophy too. In those babies, I would say it's quite usually whenever you have a babies with acute pulmonary hypertension, your septum can be useful basically to quantify the degree of the severity of your APH, but it can be tricky basically to do it in babies with hypertrophy basically. So that's just something to keep in mind. What else can we see? I
Maybe
would say,
Sarah, can I
yeah.
I don't know if Florence is able to speak. I don't want to put her also on the spot, but I would love to hear her impression on some of the lower clips that you've taken. Are you online, Laurence?
Yeah, I'm there.
Okay, great. What do you see here?
Um,
Are you still here? I think your Wi-Fi is problematic.
yeah. Yeah,
Okay,
it's really bad. Like it keeps like blocking.
so what would be this view?
Is that like the crab view? Because
Yeah.
everything is so big, it looks like weird when you don't know. But I would say crab view, yeah.
Perfect. So what do you see? So first of all, always look at the information that you have around. So, I mean, this is S12 probe, it's 21 hertz, you're at 5 centimeter from the skin. You have a 2D and color flow. You're using a resolution. You have your heart rate here, it's 128, so you get a sense of the heart rate of the patient. And then you look at your Nyquist, so you know you're filtering like at 73. So then you look in the middle, so you see your 2D, you have your color box. This is a view that's like your, pulmonary veins. So what can you see? How would you comment the pulmonary veins?
Without doing a Doppler in it?
Yeah, just by color and with knowing your Nyquist scale.
Well, you see them at a higher Nyquist, so maybe the flow is going fast.
Okay, so you have a fast flow. Is it reassuring or is it concerning if you have a case of like LV hypertrophy? Would you be reassured by that? Or would you be concerned to see that maybe the flow is well perceived at a higher Nyquist?
Well, I would just be concerned about like stenosis in the pulmonary veins if it's going
Okay.
fast. But
So I think it's good to always have the habit of saying, oh, yeah, okay, I see. Usually your pulmonary veins, we drop the Nyquist up to like 50, I
mhm.
would say, or 40. You're seeing it at 73. So it might just be that we see well the flow going through the pulmonary veins. I'm not certain that I would call this a, concern for pulmonary vein stenosis, because often if you have a pulmonary vein stenosis, you wouldn't see the track nicely the same color. You would actually see an area of acceleration. So, like these aliasing. And of course, Sarah did this Doppler, and here in this Doppler, you can actually see that the velocity are very within normal limits, and that you have all these nice peaks. And what I'm getting at is when you have very significant LV hypertrophy, Dr. Spenard just mentioned something about like what's the consequence of that into the left atrium?
It can lead to left atrium sort of hypertension and then post-capillary pulmonary hypertension. So I guess if
Exactly.
there's a lot of flow, it's good because it's flowing.
Right. So already you see the pulmonary venous flow coming back to the LA. And already I'm like, okay, you know
Yeah.
what? Like, and of course, your patient is not on like terrible amount of oxygen. The pulmonary parenchyma doesn't look so bad. So there's other signs that you check for, right? Like to make sure that there's no clinical signs of I mean pulmonary edema or increased intraalveolar transudation. But in this case, what we see is that the flow seems to be flowing unrestricted from the lungs to the LA. So already like, okay, well, I know there's a severe LV hypertrophy, but at least my pulmonary venous flow is qualitatively able to drain into my left atrium. And when I look at my Doppler, what would be the signs that you would check for that you would be concerned about for high LA pressure?
Reversal of the flow.
Right. Like during the atrial contraction, you would see like a lot of
Yeah.
reversal, or the duration of reversal would be very high. And sometimes these velocities actually are dampened. Why? Because these veins are supposed to drain against a higher pressure LA, and it's not able to do that. So when I see that, the two things I'm thinking of is, okay, my LA pressure is not so bad. Is it because my LA is truly able to drain into my LV, or is it because I have a huge ASD that's decompressing the LA, right? That's the other thing you have to keep in mind in these patients. So we're going to go through some of these echoes that Dr. Spinach got, and you're going to comment. So what do you think here? What do you see? What's this view? What's this type of picture? You have some of the answers here.
Well, it's a pulse wave Doppler,
Perfect.
and I'm trying to get like what the view is.
So what do you see here? What's this organ? These bumps, these white bumps.
Is the like la colonne, là,
Yeah, the spine. So
the spine. Yeah.
what goes along the spine usually?
Well, the
Yeah, I heard aorta, so descending aorta, and we see that it's pulsatile. So you have your QRS, you have the start of your effective systole, and then you have like the end of it. What do you think about this Doppler in general? Like the shape of it?
um, it looks like the ejection time is short,
Very
I would
short.
say. Yeah.
Exactly. So that's one of the sign, first of all, you see your upstroke is very high, like it goes to 160 centimeters per second. It's not abnormal, it's high because probably the heart is trying to compensate, so there's a fast upstroke, and your systolic duration seems to be kind of dampening, right? Like you have a very like narrow shape of your pulse wave Doppler, and that could be a sign that actually the ejection is being like foreshortened during your systole. And that could be a sign of like, the hypertrophic cardiomyopathy is, impacting a bit that Doppler flow. Maybe you're not seeing it clinically, but there's like definitely compensatory mechanisms that are occurring. So if your kid is suddenly going to become tachycardic, you may run into trouble. So what do you see here?
Apical four chambers.
Okay, so how would you describe your apical four-chamber view?
Well, there's biventricular significant hypertrophy.
Exactly. So you have both RV free wall, septum, LV free wall
Yeah.
hypertrophy. And I don't know if you can appreciate the cavity is almost like obliterating during ventricular systole, right? So it's like these ventricles. So when you see that, what are the first thing you're going to think about in terms of like eventually what's going to trickle down your management? Like in the sense, it's easy to get fooled by, how can I say that? When let's say this kid had a massive left to right PDA and it would flood the left ventricle, what would happen to the cavity of the left ventricle?
If there's a massive left
To right
to
PDA.
right PDA, and
Yeah.
then there's lots of flow into the left cavities,
Yeah,
well,
exactly.
technically they should become dilated if there's a lot of
Yeah.
flow.
So you can stent your cavity and then your muscle could be stretched actually. And sometimes we don't appreciate well some of this hypertrophy in kids who are also having like a concomitant, very large left to right post tricuspid shunt because they have so much pulmonary overcirculation. The LA starts ballooning, the LV starts ballooning, and then it's not necessarily because it's, dilated. It's just because since you have some high preload, you may like hide a bit the severity of the hypertrophy. So that's one end of the spectrum when you're trying to assess true myocardial hypertrophy. The other end is what? So the one end is like excessive preload. What's the other end?
Well, I guess not enough preload
So
would be
yeah,
the other end.
so kids who are severely depleted, sometimes they'll have these muscles that are almost touching each other, like kissing ventricles. And then it becomes a bit more difficult to know, oh, is it because my kid is like severely dehydrated and then my heart is just like trying to contract against nothing. And so sometimes you might need to give either a little fluid bolus or actually make sure they don't get dehydrated. Now, in this particular patient, when I saw this patient and Dr. Spenard saw this patient, we know this patient has been on IV fluid and well hydrated and neutral balances, and there's no other signs that this kid was losing like preload, right? So we know that this is probably true hypertrophy and not just like a preload dependency. But if you're not certain, let's say a patient coming in your unit first time you see, it's not a mistake to say, well, you know what, my LA looks small, my RA looks small, I have, what looks to me hypertrophy and kissing ventricles, maybe we should try a bit of preload. Anyways, a lot of these patients are very preload dependent, so you don't want to have them dehydrated. Okay,
And
then,
also,
yeah,
so you can see that like flow acceleration in your LV cavity. You can see that, as Gabrielle said, like in other patients, such as like your prems, like your very, very small prem, when they're in their diuresis phase, they can get dehydrated also. And so that's something that you want to watch closely, basically, in those babies too. Not because of hypertrophy, but again, because they had decreased preload.
Okay.
amazing. I think we saw this one. Here you see a bit of the MR. Okay, and that's, I think, very clearly what Dr. Spinner mentioned, like your pulse wave Doppler and the in flow velocity. So you can see that, there's definitely a much higher atrial kick than early phase of filling, which, I mean, it's hard to interpret in the early phase of these patients, but clearly, like, we suspect that there's like some restrictive physiology. Okay, now we're gonna get to this one. Yeah, what do you see here?
That's the LV outflow track.
Perfect. And what do you think about this here?
Well, it's not wide enough, I would say.
Right? You get acceleration,
Yeah,
and this
there's obstruction
happens.
and yeah.
And it happens before the valve. And eventually you
Mhm.
still get filling, right? Remember, it's like a 3D structure. It's like a tube leading to the LVOT. So, the tube is still able to pass to some degree, but you can see that the channel is becoming narrowed and you don't want to get
Mhm.
to the point that it's fully obstructed. So there's definitely some degree of acceleration. And that probably leads to intracavitary changes. You can see a bit of this MR that is in the background. What is
Yeah.
this view?
That's the three chamber view.
Okay, so
Yeah.
which organ is this in the three
The
chamber?
right, oh, sorry, the right ventricle.
Perfect. And so what do you
Well, there's hypertrophy there as well.
right? So we say in French, we say la cavité elle devient comblée. So the
Yeah,
cavity becomes very filled with muscle because the RV has like, for example, the moderator band, which can become also very hypertrophied, which is in the middle of the body. So it's also like you don't want to lose pace of what's happening on the right ventricular side. So there's clearly also,
yeah.
contributor of both sides. Okay, and then what do you see here?
I mean, those are the two atria,
Yeah,
and with the ASD or PFO, whatever,
yeah.
in between.
So do you think it's a big
And
PFO?
I mean, the image keeps sort of
It's
like
this
it's
little thing, this little flame.
yeah.
Yeah,
Well, I
so
mean, it looks like wait, can you show it again? Because the image is too sort of
He has two Laurence, but that's hard
yeah.
to see.
yeah.
Yes,
I mean,
two little shunts, but they're
Yeah.
not
one looks
massive.
like it's going really fast.
Yeah, so you're at 64 of Nyquist. One of them looks a
Hmm.
bit restrictive. So it tells us
Yeah.
probably the LA has a bit of a higher pressure than the RA, but it's not like a massive ASD that decompresses the LA. And because of that, um, that's why the pulmonary venous flow is within normal limits. So I still think, at this point in time, the baby is able to eject from his LA to the LV. So we're not at a point where you have like massively distended left atrium, high pressure left atrium. And I think if you would put a Doppler here, probably your velocities would not be so bad. But it's always
Hmm.
something to keep in mind when you see these patients. I think the day before we had done a Doppler and it was like a peak of 3 millimeters of mercury, which was still very acceptable. And then that's the last image.
Well, that's well, I guess descending aorta
Yeah.
with a PW in it.
And we see there's flow, but definitely, the velocities might
Yeah.
be a bit dampened, so something you want to keep in mind and monitor in this patient. So I think really a good review of these
Hmm.
images. Okay, I'll stop the share.
So
And
I would just say on this patient, so they were already on milrinone. And so we just I would say like so the milrinone hasn't been necessarily like we didn't like remove it just because the patient had hypertrophy, because the patient had good like they were not hypotensive. But we did go up on the SMLL in order to help basically with everything that we've talked about basically, and then we're going to repeat an echo. And most importantly, the steroid which the patient was on were decreased by half, which will hopefully help basically with the symptomatology. So that's kind of, and then yeah, that's just kind of a big picture. But again, it's not always like don't use milrinone. It depends basically on your clinical presentation. Do we have time for another case or not?
I think so. Let me just stop the recording here.
Okay.